Hello, everybody. It is time for a little cardiac part two lecture. Several years ago, our one of our former nursing program directors came over and did a little presentation in my phys lab over the summer, and we were in the cardiac unit at the time. And something he said has stuck with me ever since that day. He mentioned this not an idea, but this fact that in our hearts, electrical activity always comes before mechanical activity, or electrical precedes mechanical. And that is very true in the physiology of the heart. The myocardium, the muscular layer of heart tissue that is actually contracting and creating the mechanical force to drive blood out through the pulmonary and systemic circuits. The membrane of the myocardium must depolarize electrically before the mechanical events actually take place. And that's not my opinion. That is fact. My personal opinions might be I prefer dark roast coffee versus a blonde roast. I think Disneyland is the happiest place on earth, even though it's way too expensive and it sucks to have to order food there. The Giants are better than the Dodgers. Journey is the best band of all time. Those are all my personal opinions. However, this is not my opinion. This is fact. And so, what we're going to do here in part two is we're going to talk about electrical activity and the key parts of it that I want you to focus in on. And then we're going to talk about the mechanical events that are super important. And I'm going to leave my view like this. So that way, if there's things that I want to change font wise or terms that I want to delete and new terms that I want to insert, it's way easier in this particular view. So let's go to it. Oh, there we go. I already mentioned that. All right, now the first place we're going to start here, what we're looking at is an action potential curve of the autorhythmic cells. Now, if you remember from anatomy, and we're going to talk about this in a few slides downstream from here, but in the cardiac, what's called the cardiac intrinsic conduction system, the SA node, AV node, and so on. The cells in the SA node spontaneously depolarize roughly 70 to 75 times a minute and send that electrical wave, send that depolarizing wave through the myocardium to initiate the mechanical process. And so basically, like I said, that's where we're starting here. And so what we're looking at is the action potential curve for the SA node cells. And there's just a few things that I want to point out here. And the first and probably one of the more important things that students generally freak out about is like, oh, Rogers, am I going to have to remember numerical values of voltages and so on and so forth? No, not here. But let me point out a few different things just to have context compared to what we've talked about in the past. So if you look right about here, the resting membrane potential of this type of cell is at negative 60 millivolts. Remember, in the neuron, it was down here at negative 70. Threshold is negative 40. In the neuron, it was negative 55, which would have been somewhere right in here. But again, and we peak out at a little over zero. In the neuron, remember, it was different. There is no hyperpolarization in these cells, which is a good thing because that would just be bad for us. Okay, so don't worry about remembering, like what is rest, what is threshold. I'm not going to test you on it, okay? So let's just look at this real quick. There's three phases to this action potential. Depolarization, what's called the pacemaker potential, which is going from rest to threshold, and that is simply caused by sodium ions fusing into the cell. Phase two is actually depolarization in this context, okay? And that is caused by calcium ions coming into the cell. And then when we repolarize back down to rest, phase three, that is caused by potassium ions actually leaving the cell. So this pacemaker potential, again, going from rest to threshold in this cell, in this autorhythmic cell, this SA node cell, okay, is sodium coming in. So positively charged ions come in and we depolarize to negative 40, and then fairly quickly, phase two here, or the depolarization phase, is calcium coming in, and then we fairly rapidly repolarize because of potassium leaving. And look at that, it just repeats again. Now this, again, this action potential, this curve here is one single action potential. Okay, so clearly we see two on the screen. So this one action potential here is going to create a depolarizing wave that spreads through the heart that will lead to one single heartbeat. Okay, so we're not looking at somebody's heart rate here, but each of these two would have led to two completely separate heartbeats. Now, what I want you to appreciate here in the big picture is what's involved, okay? What I mean by that, what ions are involved, all right? We've got sodium and calcium coming into the cell, potassium leaving the cell. Now, big picture, could this process, okay, could an individual action potential, therefore could one individual heartbeat theoretically be impacted if, let's say, somebody was malnourished or was severely dehydrated and ionic imbalances occurred in the body. They had severe electrolyte deficiencies. Okay, and these three ions in particular were outside of their normal blood levels. Could that impact a single action potential? And the answer is yes. Perhaps it slows it down, perhaps it speeds it up. We don't know for sure because we're not looking at a specific set of circumstances. But what I want you to, again, just appreciate big picture is the fact that if sodium, calcium, and potassium levels in the blood are altered outside of their normal parameters, something as important as this could be affected. And I don't think that's something that we really think about on a regular basis. And let's say, in the summer months here in the valley, when it gets hot and you're outside and you sweat a lot and you get dehydrated, dehydration could affect this as well. And so, again, what I want you guys to appreciate here is the bigger picture that ionic imbalances with those three ions in particular could actually affect our heart rate. Now, in a normal, healthy individual, remember this starts in the SA node, and in particular, sodium and calcium will move from these cells to myocardial cells, and then from myocardial cell to myocardial cell. And all of these cells are connected by what we call gap junctions, which I believe I referred to on the previous slide right here. So gap junctions. Let's put that in red. Okay. Now, what are gap junctions? Gap junctions are these little protein channels between cells that connect cells, and that allows sodium and calcium specifically to go from cell to cell and spread this depolarizing wave evenly through the heart, so that the heart functions in a very, very coordinated fashion, because this depolarizing wave is spreading from cell to cell very, very rapidly. Now, when we go from SA node cell to myocardial cell, okay, we're looking at two different curves here in this particular graph. This first one here is the actual action potential curve for the myocardial cell, and it's different than anything we've seen so far. Now, the purple curve here, as it's labeled, tension development or force production curve in the myocardium. Now, let's look at this one first, and then we'll look at this one, and then we'll put the two together. All right, so sodium and calcium are coming through the gap junctions from the SA node cells to this cell. And then look how rapidly, this cell depolarizes. And depolarization here, I don't think I can change. Yeah, I can't change font over here. Otherwise, I would change colors of ions and so on, so to make it easier to see. But sodium and calcium coming through rapidly depolarize this cell to threshold. Okay, so as those ions are coming through, what's going to happen is they're going to start to open up more sodium channels, and that sodium is going to come into the cell, and again, almost instantaneously depolarize it. And then phase two here is something called the plateau phase, from about here to roughly about here or so. Now, this is something that we haven't seen so far. We didn't see anything like this in the neuron, and we didn't see it in the SA node cell. But this plateau phase here is longer. Okay, it's longer than anything that we've seen so far. It's a kind of an elongated phase. or prolonged phase, I should say. Now, what's happening during the plateau phase, as we can see over here labeled, is calcium actually coming into the cell, okay? So, and I'll kind of go over the significance of that in just a second. So calcium comes in, okay, as it says here, calcium through slow calcium channels. So it's coming in just not very rapidly, all right? And then phase 3, pretty much consistent from what we've seen so far. Phase 3, this repolarization phase, is actually caused by potassium leaving the cell, which we can see over here, potassium efflux. So it brings the cell membrane potential back down to rest. Now, this purple curve, okay, again, I mentioned it's tension development in the myocardium. Now, let's connect the dots here. What is significant about this purple curve and the relationship between it and the plateau phase? Okay, now calcium is coming in, and if you remember from back in our skeletal muscle lectures, specifically when we talked about the EC coupling, okay, when calcium floods the muscle cell, it binds to troponin, changes its shape, moves tropomyosin out of the way, then cross bridges are formed between actin and myosin. And if you remember the phrase that I drill into you, more cross bridges equals more force. Okay, now cardiac muscle tissue is very similar to skeletal muscle tissue in the fact that it has the same regulatory and contractile proteins. So troponin, tropomyosin, and then actin and myosin. So when calcium is coming into the myocardial cells here during the plateau phase, it is initiating the same contraction process that we saw in skeletal muscle. So calcium binds to troponin, troponin changes shape, moves tropomyosin out of the way, exposing myosin binding sites on the actin. Myosin binds, forming cross bridges. We get the cross bridge cycle, boom, force is produced. So look at the relationship. As calcium is coming in, look what starts to happen. The muscle, the myocardium, is actually starting to contract and produce force because of that calcium coming in. Okay, so again, the membrane depolarizes very rapidly and then begins to contract. So depolarization and then contraction is going to start right in here because of calcium coming in. That's why you don't see force production until the membrane is depolarized. Okay, so electrical comes before mechanical. The membrane of the myocardium must depolarize first, which is what we see here. Then calcium comes in and the mechanical process begins. So that's why we see what we do right here. And then as you can see, as those calcium channels start to shut down and there's less calcium coming in, cross bridges aren't forming, and the muscle is actually starting to relax in this portion here. Okay, so as the membrane is repolarizing, the muscle is actually in the process of relaxing. All right, so again, let's kind of connect the dots between the previous slide and mention the fact that if ionic imbalances occur in the blood, it's going to go so far to even impact this. For example, let's say you have high blood pressure and you go to your doctor and the doctor runs the whole gambit of tests, blood work, EKGs, everything else. And the doctor tells you after they get all the results back, Mr. Smith, it looks like your blood pressure is high because you are experiencing what we call hypercalcemia, which is too much calcium in the blood. Now, if there's too much calcium in the blood, what theoretically could happen during the plateau phase is if there's more calcium in the blood, when this phase actually occurs, if the concentration gradient for calcium is higher than normal, more calcium could technically come into the myocardial cells during this phase. More calcium, more cross bridges, more force. So if a person has too much calcium in their blood, that theoretically could actually increase their blood pressure. And if that was the case, perhaps a doctor might try a calcium channel blocker as a method to manage this person's blood pressure and hopefully get it back down to normal limits, even if the blood calcium levels remain too high. Okay, and kind of the same thing back over here in this slide. If there was too much calcium in the blood during this depolarization phase, if more calcium came in, it would technically cause this particular cell to depolarize more rapidly and actually increase the heart rate. So calcium we mostly associate it with bones, but it has a pretty profound impact on cardiac function as well. All right, so let's move on. Now we mentioned the cardiac intrinsic conduction system. Okay, now in a normal healthy individual, okay, like we've been talking about with our first action potential curve, the first step is right here in the SA node or the sinoatrial node, kind of in the superior / posterior portion of the right atrium. Now, that depolarizing wave starts there and then spreads through both atria simultaneously, coming back to this point here called the atrioventricular or AV node. And it spreads because of gap junctions. Gets back to the AV node. Now there's a 0.1 second delay here at the AV node before it passes through to the AV bundle. Now that is very significant, but I'm not going to explain it right this second. We'll explain it in a few minutes when we get to the what's called the cardiac cycle. All right, so it passes through here. Now there's no gap junctions right in this area here, and so the AV bundle is actually what is going to carry that wave through to this area called the interventricular septum, where we have the bundle branches. Now, this is real deep, so you might want to kind of, hold on to your chair or wherever you're sitting, kind of brace yourselves for the truth that I'm about to drop on you. This is called the right bundle branch, and this is called the left bundle branch because, yeah, you guessed it, there is a right and a left side of the heart, like there is a right and a left side of the body. So the right and left bundle branches are going to carry that depolarizing wave through the septum to the apex of the heart, where we will then move into what's called the subendocardial conducting network or the Purkinje fibers. And then the wave will be carried all the way through the ventricles of both sides. Okay, now this whole electrical network is modified muscle fibers that don't have the capacity to contract, but they are capable of spreading this depolarizing wave through the myocardium so that, again, the electrical part of this process can lead to the mechanical part of the process. Now, in a normal, healthy individual, it goes in this exact sequence: 1, 2, 3, 4, and 5. Okay. However, if and you guys know this, we don't remain perfectly healthy. Unfortunately, there is sickness and disease in this world, and if something goes wrong here, it will translate into a kind of a negative impact on cardiac function. Now, 3 of these 5 areas are actually capable of determining the heart rate. We already know that the SA node that's the chief one that depolarizes at the fastest rate. So that's why it's called our pacemaker. It's the body's natural pacemaker. All right. Now, if the SA node does not work enough or work properly, the AV node could actually generate the heart rate, but at a slower rate. Okay, so SA node first at the fastest, and then the AV node second, but slower than the SA node. And then third on the list is actually the Purkinje fibers. So from fastest to slowest, SA node, AV node, Purkinje fibers. I'm not a cardiologist, even though I used to play one on TV when I used to star on that show, ER. No, I'm just kidding. I never starred in the ER. I used to work in one, but not on television. So I'm no cardiologist, but if somebody's Purkinje fibers are actually regulating their heart rate, my guess is that they're probably not going to be with us much longer. I haven't looked up the stats for it, but I want to say that you're probably looking ballpark 30 beats a minute. Would be my guess, 30 to 40 beats a minute. I think if I don't know if this slide tells us, 30 roughly 30 times a minute without input from the other areas. So, yeah, the person's not doing too well if it gets to that point there. All right, now, if something goes wrong in this network, it generally will show up on an EKG. So that would determine, or that would technically be classified as an arrhythmia, an irregular heart rhythm. Now, that's going to again have some sort of negative impact depending on where in this network the actual issue is. And we're not going to learn about different arrhythmias in this particular class. There is actually an extra credit assignment on it, but it's optional. Now, if you go on to bigger and better things in healthcare, you'll take obviously advanced coursework in this and take EKG classes where you will learn about different types of arrhythmias and why they are caused. But for this class, we do not get that deep. Okay, so arrhythmias can be life-threatening. Not all are, but some of them, if not treated immediately and properly, could result in death. And so that's obviously not ideal, whether it's defibrillation or something called cardioversion. Some arrhythmias need to be dealt with extremely quickly. Okay, now I want to get to this. All right, now as we've been talking about, the stimulus for cardiac muscle contraction comes from the heart itself. Starts in the SA node. So that tells us that in order for the heart to beat, it doesn't need stimulation from the central nervous system like skeletal muscle does. However, our body does have cardiac control centers in the medulla oblongata that influence heart function. And that's what I wanted to show you here with this. So in the medulla, okay, we have two distinct areas that can influence heart rate. Okay, we have what's called the cardioinhibitory center and the cardioacceleratory center. Now, there is a third center called the vasomotor center that I'll talk about in the fourth cardiac lecture, but that particular area influences blood vessel diameter through manipulating smooth muscles in the heart. So here, however, in blood vessels of the heart in the coronary circulation. But here in particular, these two centers are going to manipulate heart rate. The cardioinhibitory center will send parasympathetic impulses to the heart, and the cardioacceleratory center will send sympathetic impulses to the heart. Now, again, this is pretty mind-blowing stuff, but you could imagine what kind of impact would impulses from these two areas have on the heart rate. So if we get impulses from this guy, okay, what do you think is going to happen to the heart rate? Okay, hopefully you just answered it out loud. Yeah, you guessed it. The heart rate's going to go up if this area sends impulses. If this area sends impulses, yep, you guessed it, heart rate is going to go down. Now, obviously, this is in the brain. This is the heart. They are not next door neighbors. And so we're going to have to get impulses from here to the heart through nerve fibers. So if the cardioacceleratory center is going to get impulses to the heart to stimulate the heart rate, let's say it's a fight or flight situation, okay, and we need to react to something. Impulses will go from this area in the medulla along what's called the sympathetic cardiac nerves to the heart. And look at the three areas those nerves synapse with: SA node, AV node, and Purkinje fibers. Now, if you remember to all those many seconds ago that we talked about this, okay, what do those three areas have in common? Okay, the SA node, AV node, and Purkinje fibers all have the capacity to regulate the heart rate. So it's extremely, extremely convenient that this area sends impulses to the three areas that can affect heart rate. Okay, so again, in a fight or flight situation, if the brain sends signals to this area, guess what? The heart rate's going to go up, and the force of contraction, how strong the ventricles contract, is actually going to go up as well. Something actually we're going to talk specifically about in the third cardiac lecture. Okay, and then the cardioinhibitory center is parasympathetic in nature, and if we get parasympathetic impulses to the heart, they will go along cranial nerve number 10, the vagus nerve. And in this case, what happens in vagus does not stay in vagus. So it'll go along the vagus nerve, synapsing with the SA node and AV node. Now, parasympathetic impulses to the heart are going to slow down the heart rate. Okay, now neurotransmitter wise, typically what we're dealing with here is these sympathetic cardiac nerves are going to release epinephrine and norepinephrine, and the parasympathetic nerve fibers are going to release acetylcholine. So those specific neurotransmitters will actually have a direct and profound impact on cardiac function. Okay, so again, as we can see, the heart does not need the nervous system stimulation to directly begin the electrical wave that initiates the heart rate. However, the brain can get involved if necessary. Okay, now, quickly, I wanted just to mention EKGs, okay, or ECGs, electrocardiogram. EK, I believe the K, oh my gosh, I never remember. It's was it Latin? I want to say. I don't remember. I probably should have looked that up before I even brought it up, but oh well. So an EKG, this is a typical diagnostic tool that you will see in healthcare. When I was an ER tech all those years ago, this was one of my main jobs that I did. When my ER shift was 7 a.m. to 7 p.m., but I had to get there at 6:30 because I'd have to go over to the med surg floor to see if there were any EKG orders from the overnight doctors that they had ordered on the med surg patients. But if anybody came into the ER and the doctor ordered an EKG, that was one of my main jobs. And so I did this on the patients. Now, this is a very useful diagnostic tool. And in this class, we do not get into any depth at all in this process. However, we want to introduce it and inform you about what it is and why it's important. Okay, because if we're measuring the electrical activity through the heart, through the intrinsic conduction system, this is the physical way that we will assess it. Okay, so the doctor or the tech or whoever's doing the test will put the nodes over a person's chest, shoulders, and typically the areas of the legs or hip areas. Now, we can assess the electrical activity through that 5-part intrinsic conduction system. So we have what's called, your typical tracings are right here, and it's all based on time. Okay, so how rapidly or how slowly is the depolarizing wave passing through the myocardium? So your typical tracings are right here. We have the P wave, we have the QRS complex, right here in the middle, this big guy right in the middle. And then we have the T wave right here on the right side of the complex. Now, they all stand or represent something different. The P wave represents atrial depolarization. The QRS complex, ventricular depolarization. And then the T wave, ventricular repolarization. Now, remember, electrical comes before mechanical, and the myocardium must depolarize before it contracts. So after the atria depolarize, they will contract. Now, if you notice, atrial depolarization, and then we have depolarization and repolarization for both ventricles, but what are we missing? We're missing a deflection for atrial repolarization. Now, the reason we're missing it is it would have to be right in here. But in terms of the electrical activity that's going on, this is way stronger, and so that's why it masks anything that we would see for the atria happening. Okay? Now, the reason I mention this and these different intervals and segments obviously mean something different, which you can see here on the previous slide. Okay? Now, the reason we want to address this is because a doctor will need to do one of these. Typically, if a patient goes into a doctor's office or an ER complaining of chest pain, this will be one of the first things that a smart doctor will actually order. Okay? And because, again, we need to find out what's going on with the electrical activity in a person's heart. Because if something is not going through the 5-part intrinsic conduction system efficiently, the heart itself will not be contracting in a coordinated and efficient manner, which will theoretically lead to an arrhythmia, possibly life-threatening one. Okay? So that's why this test is important. Super important. My job when I used to do them as the tech, my job wasn't to read and interpret them. I would wheel my little cart up to the patient's bed. I would do the test, and I would hit a button after I put in all their data, and then I would rip that page off the machine as it came out, and I would go and I would put it in the hand of the doctor before I unhooked the person. And the doctor would look at it and say, "Oh, okay, thanks. Just put it in their chart. Everything looks fine." Or only one instance do I actually remember doing the test, taking it off the machine, putting it in the hand of the doctor, and the doctor saying, "Oh, this person's having a heart attack. Let's go." And then the doctor starts, giving orders. You do this, you do that, and telling all the staff what we needed to do. And unfortunately, if you've ever worked in healthcare, unfortunately, you're not always able to save people that have cardiac events. That individual we actually were able to save, but there were a few that we weren't. So very important, very useful diagnostic tool. All right, my friends. Actually, I'm going to take a quick drink of water here. Excuse me. Okay. All right. Now, we've been focusing on the electrical activity. Now we need to get to the mechanical activity. If you need to pause this and take a little break, go for it. One of the knocks against me whenever I get evaluated is that some people, one of my administrators will say, "You need to break your lectures down into small chunks." I'm not a big fan of that. I prefer just to knock everything out in one chunk, and then if you need to stop, just pause it, for heaven's sake, rather than making a bunch of little individual videos. I'll just make a big friggin' one. Okay, so mechanical events of the heart. So we need to talk about contraction and relaxation, which refer to two terms that you are probably already familiar with: systole and diastole. It's not systole or diastole. Systole and diastole. If you've worked in healthcare before, maybe you're a CNA, you're an LVN, EMT, paramedic, you've probably learned how to take a person's blood pressure. Okay. And whenever you take those numbers, you say, "Oh, the patient's blood pressure is 120 systolic, over 80 diastolic." Okay. Have you ever wondered where those terms come from? Okay. Well, now you're going to learn. So systole is a term that refers to the period of contraction in the heart. And remember, all four chambers of the heart contract. But when the atria contract, they are sending the blood in the ventricles. And then, like I talked about in cardiac lecture number 1, when the ventricles contract, that's what drives blood out of the heart through the two circuits, pulmonary and systemic circuits. So whenever we talk about systole and systolic pressure, we're really focusing on what the ventricles are doing. And the same thing here with diastole, okay, is the period of time that the ventricles specifically are relaxing. So systole and diastole are not referring necessarily to actions, but periods of time. Okay, systole, diastole, referring to contraction and relaxation of the ventricles. Now, the cardiac cycle is a sequence of events, as it says here, blood flow through the heart during one complete heartbeat. So what is going on through the heart mechanically, okay, during these two periods of time? What's going on when the heart is relaxing? What's going on when it's contracting? What are the chambers? What's going on in the chambers? What's going on with the valves? What's going on with volume and pressure in the different chambers, and so on? And so that's what we have to focus in on here, is what is the cardiac cycle? What's going on in the heart while it's relaxing and while it's contracting? Okay, so there are four phases. Now, this is something important to remember, is there is not a cardiac cycle for the right side and a cardiac cycle for the left side. There is one cardiac cycle only. So literally what's happening on the right side is also happening on the left side simultaneously. Now, whenever we measure a blood pressure, we're actually measuring the pressure associated with the left ventricle, and the pressure be kind of in the aorta, but that's directly associated with what's going on in the left ventricle. Okay, now, and that's just blood pressure. Okay, all right, let's get to phase 1 here. So phase 1 is called ventricular filling, and it occurs during mid to late diastole. So that tells us that this phase is occurring while the ventricles are relaxing. Now, it's really mind-blowing. So again, you might want to brace yourselves for the knowledge that I'm about to drop on you. Okay? Ventricular filling. What is going on during this phase? Well, if the ventricles are relaxing, look what's happening. They are filling up with blood. Again, real deep, right? Incredible, mind-altering things here. So the ventricles are filling up with blood. So imagine what's going on, okay? The ventricles are in a period of relaxation. Blood is coming back to the heart through the venous system, through the superior, inferior vena cava, the coronary sinus, and it's coming back into the right atrium. Blood from the right and left pulmonary veins is coming back into the left atrium. And as that blood is coming back, the pressure in the atria is higher than the pressure in the ventricles. So that tells us that the AV valves are shut. Okay. And because blood has actually just left the heart, and because the ventricles have just contracted, the semilunar valves are actually shut because the pressure in the pulmonary trunk and aorta are higher than the pressure in the two ventricles. So you've got a situation here where the AV valves are open and the semilunar valves are shut. So this blood that is coming back to the heart is coming into the atria and then moving passively on into the ventricles. So passively, when I highlighted this term here, what I'm implying is that there's no contraction going on in any of the four chambers. So the ventricles fill up with 80% of their total capacity of blood. So again, the blood is coming back through the venous system on the right side and the pulmonary veins on the left side, coming into the atria and then moving right on into the ventricles. And remember, the ventricles are able to fill up to about 80% of their capacity because semilunar valves are shut. So as they are filling up, okay, the atria depolarize. So the SA node fires, and that wave goes through the atria, and they depolarize. Okay, now remember, depolarization comes right before contraction. So the atria depolarize, and then look what happens. They contract. Okay, and so then in this active portion, because remember this is kind of referring to, it's not a subphase officially, but this passive portion, this early portion of phase one, we often call a passive portion of it, because again, nothing is contracting and the ventricles fill up with 80% of their blood. And then once the atria depolarize, they contract, and we kind of go into this active portion of the phase where the atria contract and then fill up the ventricles with that remaining 20% capacity that they need to reach 100%. Now, once they hit that max capacity, if we hit the pause button, okay, if you've ever played video games, generally there's a pause button, okay? So you can pause a video game, okay? If we paused this circulation, at that moment, the volume in the ventricles at their max capacity is something called end diastolic volume, or EDV. Okay, so end diastolic volume, EDV. It sounds like a Law and Order series. Law and Order, or FBI, EDV. Okay, so the volume of blood in the ventricles at the end of diastole. So once the ventricles have at the end of that period of time when they've relaxed and they're full of blood and ready to contract and ready to push out their blood, that's what EDV is. Okay, so thankfully now, as we can see in this point, that wave of depolarization does not stay in the atria. It has spread through to the ventricles. Okay, so where are we at the end of phase one? Okay, at the end of phase one, the ventricles are full. The atria have contracted, which is why the ventricles are full. The atria are relaxing, and now that depolarizing wave is spreading through to the ventricles to bring us into phase two. Okay, phase two occurs in early systole, so that tells us that the ventricles are starting to contract. Okay, so the ventricular myocardium depolarizes, the ventricles contract, And now, as they are contracting, okay, they're starting to contract. Now, the pressure in the ventricles has been increasing because of them filling up with blood. So when ventricular volume goes up, the ventricles start to expand, okay, and the myocardium starts to stretch because of it accommodating blood. And the pressure inside of it, the pressure against the ventricular walls is increasing because of the volume of blood. It's pushing against them, stretching the myocardium, and so pressure has already been building. Now, on top of that, you add in the fact that the ventricles are now starting to contract, the ventricular pressure keeps rising. And it's going to get to a point where it goes higher than the pressure in the atria. And if you remember from our first cardiac lecture, what opens and closes the cardiac valves are when pressure differences occur on their two sides. So when ventricular pressure exceeds the pressure in the atria, look what happens. The AV valves shut. So we have a unique situation here, implying, or which is what tells us why we get this name. So phase 2, like I didn't mention it yet, is named isovolumetric contraction. Iso, as the prefix, means equal or same. So we have an instant or a unique situation here where the ventricles are completely shut. The AV valves are shut and the semilunar valves are shut. So if you think about it physically, nothing is coming into the ventricles and nothing is leaving. So for a split second, we have the same volume in the ventricles while they are in the process of contracting. So isovolumetric contraction. Literally the same volume in the ventricles, it's constant while they are in the process of contracting. So they're contracting. Now the pressure there, the ventricular pressure, still hasn't exceeded the pressure in the two great vessels, the pulmonary trunk and the aorta. But thankfully, we don't stop here. We go into phase 3, which is called ventricular ejection, which probably tells you what's about to happen. All right, so we're still contracting, late systole. So the ventricular pressure is still rising because of them contracting. And now it gets to the point where ventricular pressure is higher than the pressure in the two great vessels, the trunk and the aorta. So what happens? When it finally exceeds the pressure in those big arteries, boom, the semilunar valves open. So the pulmonary valve opens and blood goes from the right ventricle through the pulmonary valve into the pulmonary trunk. When left ventricular pressure exceeds aortic pressure, boom, aortic valve opens up and blood leaves the left ventricle and goes into the aorta. So ventricular ejection literally implies and tells us that the ventricles are ejecting their blood. Now, when the aortic valve opens up and blood goes into the aorta and the pressure there in the aorta, the pressure against the aortic walls because of the blood, that is the specific pressure that we're actually measuring when we take somebody's systolic pressure. And on average, it's 120 millimeters of mercury. Now, once the ventricles eject their blood, okay, we can measure the volume in the ventricles, and it's never zero. They don't ever fully eject their contents. And so whatever blood is left over after they contract is called end systolic volume, or ESV. So how much blood is there at the end of systole? Okay, so what is left over after they contract? And again, it's never zero. So the ventricles never fully eject their blood. And here we have a term that we're going to get into more depth in the third cardiac lecture called stroke volume, SV, and SV equals EDV minus ESV. So literally this is how much blood is there before they contract, how much is there after they contract, and this tells us that volume, or you take the difference, and then that gives us this particular volume here. Okay, so SV equals EDV minus ESV. And like I said, we're going to talk more about stroke volume in depth in the third cardiac lecture. All right, so we transition now into phase 4. So ask yourself, what just happened? Okay, what just happened in phase 3 was the ventricles ejected their blood. And now, after they've contracted and ejected their blood, they start to relax. So early diastole. Now, phase 4 is called isovolumetric relaxation. All right, so that's what just happened. The ventricles ejected their blood, and because of that, we have a pretty rapid drop in ventricular pressure as compared to the pressure in the two great vessels. So as ventricular pressure is dropping, okay, the semilunar valves actually shut because the pressure in the vessels is higher. Now remember, keep in mind also that the AV valves are still shut. So when the blood has left the ventricles and they're relaxing and we have a drop in pressure, the semilunar valves shut, and for a fraction of a second, all 4 valves are shut. And that tells us that nothing is coming into the ventricles and nothing is leaving because the blood actually just left. So isovolumetric relaxation, phase 4. Iso, again, meaning equal or same volume, while the ventricles are relaxing. Now, thankfully, pressure doesn't stop. The pressure continues to drop. Now, ventricular pressure does drop below atrial pressure. And so when that happens, the AV valves open up, and guess what? The whole cycle starts again, assuming that the person is alive. Okay? So, my friends, that is the cardiac cycle. Now, this slide here does a good job, and it's like super small 0.25 font. You probably can't even read it while you're watching this video, but if you have this in the PowerPoint, which you should, you can enlarge it. But I really like this particular slide because it shows us what's going on in the heart from multiple angles all at the same time. So your EKG tracing here, okay? What's going on with pressure changes in the different areas, volume changes during the so this is all during the cardiac cycle, okay? Because you can see down here, phase 1, 2, 3, and 4. They break it down. Now, don't freak out. Okay, I'm not going to take this particular graphic, take all the words off and put it in the test and make you fill it in. Okay, I'm not going to do that. However, this is a really good slide to give you a bigger picture view of what has been going on. All right, now 2 more things here. Heart sounds. Okay, and this is going to kind of as I'm winding down here. These last 2 slides are basically setting up one of our labs. Okay, so we've been talking about the mechanical action going on and the valves opening and closing for blood to leave the ventricles, or closing when they get full. Now, your typical lub-dub that we associate as the heart sounds. Now, those heart sounds are caused by the closing of the 4 valves. So when the AV valves close, okay, when the AV valves close and when the semilunar valves close, that's what produces the lub and the dub. So the first heart sound we hear is the closing of the AV valves. The second sound, the dub, is the closing of the semilunar valves. Okay. Now, what you need to make sure you figure out, and we'll go back over these slides here to point it out, is when. Okay, when this is actually happening. So if we go back, all right, and let's go back to phase 1. Okay, do we see any valves closing during this phase? If we look through here, we don't really see anything referring to valve closure, because remember, in order for the AV valve to shut, ventricular pressure actually has to get higher than atrial pressure. So if we go to phase 2, oh, look at that right there. So the AV valves close during phase 2. So that the first of the 2 heart sounds, the lub, is going to occur during phase 2. Okay, and then if we go here, nothing in phase 3. We go to phase 4 and look at right here. The semilunar valves close. So that would be the dub. Okay, so we go back here. So our heart sounds, lub dub, lub dub, lub dub. The first sound is during phase 2 of the cycle. Second sound is during phase 4 of the cycle. Okay, and I hopefully pointed this out in the first cardiac lecture. Make sure, you must know, it's not a suggestion, you must know how all four valves open and close. And then the last slide here that I need to address is really setting up our one of our labs. In one of our labs, we're gonna do manual blood pressures, upper and lower extremity pulse checks, and we're going to listen for heart sounds. And this particular slide simply shows you where to put your stethoscope to listen for the sounds coming from all four valves. If you look up here, these first two, so up here on the upper chest, okay, we're dealing with the sounds coming from the pulmonary, or sorry, the semilunar valves. So they're in the second intercostal spaces at the right and left sternal margins. The AV valves are in the fifth intercostal spaces, tricuspid valve in the right sternal margin, but the mitral valve kind of in line with the middle of the clavicle, not sternal margin over here. Okay, so just a quick little setup of what we'll actually do in lab, but very important information for you to know, and it probably will be on your cardiac exam. Just saying. Okay, so that wraps it up for part two. Um, Again, I hope you got some good information out of this. If you have questions, don't ever hesitate to reach out, and I will get back to you as soon as I can.